This is a really difficult video to make. Even knowing where to start is tough. But there's, I guess I made some notes here. This is a really difficult video to make, and it's on a difficult subject, and it's probably not what most people want to be listening to. So let's be clear what this is about. This video is aimed at anyone who's got a prostate. If you don't know whether or not you got a prostate, let's start with you'll have a prostate if you were born male. Okay, you should know whether or not you were born male. If you were born male, you've got a prostate. This isn't going to be a quick video, all right? I have a prostate. I have cancer in my prostate. So let's tell you a bit about me. I'm Stephen. I'm 53 years old. I've been fit and strong all my life. I always worked outdoors making stuff. I'm a carpenter. I run a small company here in Ipswich in Suffolk. We sort out people's homes. We make stuff. We make furniture and things like that. This is Jack, my dog. In case you're wondering, just save you having to ask in the bit underneath. He's a Prague ratter called Jack. I have a beautiful wife, Maria, who's done a lot of the research for me on this, because basically my head couldn't deal with it. And between us we got 5 kids, all of which are grown up now. 3 boys, all of them could at some point in their lives have prostate cancer. For every 8 people who are watching this, one of you has got or will get prostate cancer. The good news is that the vast majority of prostate cancers, and I believe there are about 20 different sorts, the vast majority of prostate cancers are very slow growing. Don't do that, Jack. Sorry, he's got a sore leg and he's chewing at his bandage. The vast majority of prostate cancers are very slow growing. That is to say, they take decades to become an issue. The other good thing about prostate cancer, for most, if there is a good thing, it's a struggle finding good things. Hopefully this video will be a good thing. The other good thing about most prostate cancers, they're slow growing and they don't present any danger to life to most men until they're in their 70s, 80s, or even later. And because they're slow growing, in most cases, the treatment is simply to slow it down enough that you die of old age and not die of your prostate cancer. One of the people I've met on this journey of discovery about prostate cancer, eminent surgeon, told me that, get the facts right, 8 out of 10 men will die with cancer. But that is with, not of. I think that tells you a great deal about how cancer works in the body, and maybe you should be scared of it, maybe you should be not scared of it, but I think you need to be aware of it. And prostate cancer is, it turns out, is a hidden killer. It's for me, I'm thinking of it as a ticking time bomb. Shall I tell you how I found out about it? Okay, symptoms. If you look up, okay, so you could be watching this anywhere in the world. I'm in the UK. There's a charity here called Prostate Cancer UK. They have a website, and their website lists a load of symptoms. There's probably a dozen symptoms. Number 2 to 11 if you're suffering from any of those, you're probably already in a very bad way, and very bad as opposed to bad. If you're lucky, you've got the first one on the list that you become aware of, and the first one is okay, guys, you know, you might want to just make sure you're sitting in a room on your own at this stage, because we're going to get personal. We're going to start talking about the way your body works. The first one on the list is about how you pee and whether or not you can pee at all. You know, when you're a kid, you can pee, you can shoot it about 10 foot, you can spray the wall, you know, you're standing at a urinal, you can get it all the way up there somewhere. Now, it's quite normal as you get older for everything to harden up apart from your cock. But everything hardens up, whether that's the lenses in your eyes and you get short-sighted, or your joints and bones and things. And it also applies to your urethra and all of those sorts of bits which are inside your waterworks, which affect how you pee. So it's quite normal for that to be affected as you get older. But one of the first symptoms of prostate cancer, which I was aware of, was I went from being able to pee normally to, over a relatively short period of time, and I'm talking a matter of a few months, a handful of months, it went from a nice steady flow to a dribble. You get an urge to go to the loo about every 2 hours. You get there, and although the urge is there, nothing starts. And when it does start, it starts slowly, and then it just dribbles, and you have trouble getting it past the end of your boots, let alone splashing against the wall behind you. And then when you think you're finished, it's still dribbling. Sorry guys, I know this is personal, but this is the way it really is. I'll explain a bit about the anatomy, right? Inside you, imagine your bladder. I'm holding a bladder, and urethra comes out the bottom of it, and looking like a little ring donut on the underside of your bladder is your prostate, and your urethra goes straight through the middle of it. Turns out it's actually the shell of the prostate is actually intrinsic with the wall of the urethra. They're one and the same thing at that point. The prostate might be, imagine like a satsuma skin around a pithy core, apparently. I've not seen one, I can only tell you what I've been told. Just like any other tissue in the body, if you get any kind of infection or scratch or dent or whatever in your body responds to it with becoming inflamed. And that inflammation, like swelling, when it's your prostate, squeezes on the urethra. And that's why you get this problem peeing, because it's actually squeezing the pipe where your urine is trying to leave the bladder. Now for me, I can consider myself fortunate to have taken myself to the doctor when I was aware of those symptoms. I don't know, if I hadn't, it would have been a lot worse. The earlier you go, the better, okay? Just take that from me. If you're not going to watch this video any further, if that's enough, if you've heard enough, then just take yourself to the doctor now. Pick up the phone, call them, say, I think I might have a problem with my waterworks, and they'll take you in. I can tell you what happens. Okay, so if you're in the UK and you just go to see your GP, what they're going to do is they're going to ask you to do a delivery. Would you believe it, in the middle of this, my dog's being sick all over the floor. Little bastard, we'll sort him out in a minute. You go to the doctor, they're going to ask you to give a urine sample. They're going to dip it and look for infections, because 9 out of 10 times, this is good news, 9 out of 10 times, if you've got a problem with your waterworks, it's an infection. you're much more likely to have some kind of bladder or a urine infection, or what they call a UTI, urinary tract infection. You're much more likely to have one of those than you are to have prostate cancer, quite honestly, particularly if you're in this like age demographic that I am. And so I went to the doctor and they took a urine sample, and they said, unfortunately, we didn't find an infection. That doesn't mean to say that it's cancer. There's another type of infection you can have, which is actually is buried deep inside the prostate rather than in the urinary tract. And so if you've got that, it only shows up on a blood test. So that's the next thing. Send you off, get a blood test. They do a blood test. They take a sample and they do 2 tests with it. They'll look for that infection, but they'll also do a thing called PSA, prostate-specific androgen, or it's an antibody that your body's producing when you have prostate cancer tumour cells growing in your body. Your body responds by producing this thing, and it's measured as this PSA number. If you're a young man, if you're in your 20s, that number will be more or less 0. Should be more or less 0, because you shouldn't have any cancer tumour cells, any prostate cancer tumour cells growing in your body. If you have, then your body will be producing PSA. That is to say, if I've understood this correctly, about 7 out of 10 of the different types of prostate cancer give a useful PSA reading. So you're not necessarily going to have a raised PSA if you've got prostate cancer, but 7 out of 10 times, and with all the common cancers, you will have. Okay. I went and I did the blood test. I had a raised PSA. Now my PSA was just short of 20. If you do your research, you look it up, you'll see that for a man of 53, your PSA should be about 3 or 4. I believe with UK GPs, if your PSA is 5, then that's an automatic referral for more investigations. So as I say, mine was nearly 20. So what do they do next? They send you off to... oh no, the GP did one more thing. They do what they call a digital examination, which on the face of it you think in this modern world would be some high-tech piece of kit. It's not. They're talking about this digit. You're going to be asked to bend over and they're going to stick a finger up your bum. To be fair, it's a bit of an antiquated test. If someone, perhaps not you, if someone sticks a finger up your bum and feels your prostate, they can reach it, but just imagine, they can only get to one side of it. And if they're lucky, they can get to a whole half, but they may not be able to. It depends on your BMI and things like that. And so if your tumour, if you have a tumour and you believe it's in the prostate, if it's on the front of your prostate, they're not going to be able to feel any lumps or bumps on the back of it. So it's a pretty pointless exercise. So you'll be probably less than 50% of all prostate cancer tumours are going to be physically detectable with a digital examination. So don't be led by the results of that finger up the bum test. It's only part of a diagnostic process. The dog's finished being sick. I'll clean that up later. Okay, so what happens next? You've got a raised PSA. It's definitely not an infection, so they're not going to be treating with antibiotics. So you're now on a journey through finding out what your prostate cancer is and how bad it is and where it is and all those sorts of things. You feeling better now? Come here. So next, what's next on the list? They're going to ask you to go in, if you're in Suffolk, in Ipswich in particular, which is where I am, the local hospital has got a fast-track diagnostic facility for urinary tract infections and other urinary problems. Turns out to be a good thing. It's run by a bunch of specialist nurses. They know what they're doing. They know what tests to do. They'll do all kinds of pee in a bucket and check the flow rate and things like that. They'll do ultrasound scans on you. They'll look at, they'll do like early assessment stuff, questionnaires and other blood tests and things like that. They're probably then going to refer you to do an MRI. An MRI is a very accurate way for them to see where or if the tumour exists in your body. So that's what I did. I went and did an MRI, and the results of the MRI show them where the tumour is in the prostate, what volume it is, and stuff like that. And from that, they're going to do a biopsy. They're going to want to, because at the moment all they've done is identified some tissue which is in your prostate, which it doesn't look like what it's supposed to look like. So they actually want to know whether or not this is life-threatening or not. So they're going to do a biopsy. The biopsy is bloody uncomfortable, quite frankly. A thing stuck up your bum and making lots of holes, a dozen, I believe, a dozen samples, needle core samples, deep into your prostate, and then those samples are taken away, and they're going to do whatever marker, test, growth, whatever they do to find out whether or not there are tumour cells in there and what sort of tumour it is. They can find out what sort of cancer you've got from that test. They did that test. They came to the conclusion from the MRI and the biopsies on me that I have what they call a T3B. The B refers to the fact that the tumour has broken outside of the shell of the prostate, so it's no longer contained within the prostate. It's actually starting to infect tissue outside of the prostate. In my case, it's a thing called the seminal vesicles. So they consider it aggressive because it's got outside of the prostate, but still localized because it hasn't really gone beyond there. At this stage, it's starting to get really, really scary. The next one they do is they send you for a radioactive bone scan. You go in and the morning, for me it was, they give you an injection. The injection has got a radioactive marker in it, and a few hours later you go back and they scan you with a machine that's looking to find out where that radioactive marker has lodged itself in your body. It's a marker which is designed to only show up where the tumour is, but what it will do is it will show up whether or not the tumour has grown and cells of it have managed to bridge from where it is locally to the bloodstream or lymphatic system and be distributed around your body, and whether or not it's affecting any other part of your body. Good news for me, it hasn't, or it hadn't when they did that, which was about 6 weeks ago. At this point, we now know exactly what the problem is. We can start making some plans about what treatments are available. So, T3B, localized, aggressive, Gleason's score 7, 4+3. I hope you never have to find out what all these things mean, but if you're interested, that's what it is. Considered treatable at this stage. This is where you start learning that cancers fall into one or two categories, either treatable or maybe 3 categories. The earliest category is they've got something they've spotted which they just want to keep an eye on. That means that they really don't think it's worth investigating at this stage, and they're going to say come back in 6 months or a year or something. I can't remember what they call that in this context, but anyway, there's that. If you got that, good, keep an eye on it, do what the doctors tell you. Next stage is treatable. That is that they think that they can do something to rid you of your cancer. And the third stage is where they manage the problem. That is, they know it's going to kill you, and all they can do is look at ways of delaying that process. If it's into your bones, for example, then they're not going to offer you surgery because they can't remove all your bones. Surgical options. Let's talk about that, shall we? Are we at the moment where we can talk about that? I think we can. Surgery is what I've been offered. It's treatable. Surgery is what I've been offered. So, here in Suffolk, I get referred to Adam Brooks Hospital in Cambridge, where they have a robot keyhole surgery thing they do. You might have heard the reference if you're into this. I'm sorry that you're into this, but if you're into this, the Da Vinci robot, which is for doing this kind of microscopic keyhole surgery. Why does it need to be keyhole, and why is it microscopic? Well, the prostate's not very big to start with, and it's buried deep inside your pelvis, and it's surrounded by all kinds of important stuff which you don't want to damage, like the bladder and the bowel, and a whole lot of nerves. Guys, sorry, I'll come to this later. Nerves are important, okay? Just lodge the term nerve sparing. Okay, we'll come to that in a minute. Hey. Excuse me a minute. Wait. There's nothing happening, it's just a bird. Oh, no. It's alright, he's just guarding me. Okay, let's talk about the different treatments. In my case, the primary treatment that I've been offered and recommended is surgery. It's a robotic radical prostatectomy. On the NHS, carried out by the surgeons at Adam Brooks Hospital using the Da Vinci robot. We're not going into that. If you want to know about Da Vinci robot, just Google it. There's all kinds of interesting stuff online. It's a technique that they've been doing for about 10 years or so. They're quite well practiced at it. They know what they're doing. They go in from your front, just above your pelvic bone. They make a number of small incisions, that term, and approach it from a couple of different directions, different probes with cameras and lights and knives and all those kinds of things. And if you go with the NHS and you have this level of tumour where it's broken outside of the shell of the prostate, they're going to recommend that they remove entirely the prostate and the seminal vesicles. They do this by cutting between the prostate and the bladder, which disconnects the urethra from the bladder, and then they cut where the urethra exits the prostate. They remove the prostate, and then they reconnect the urethra to the bottom of the bladder, put in a can't remember what the thing's called, a pipe to hold it all open while it's healing, and to drain your bladder, and more or less that's it. It's a relatively straightforward piece of surgery. And you think, yeah, great, okay, so if I've understood it correctly, all of the tumour is inside or around the prostate, and by chopping it all out, you've removed that tumour from the body, and the cancer's gone. And if you say to the surgeon, so, why would I choose surgery? He'll tell you, because we'll get it out of you. What he doesn't tell you, unless you specifically ask the question, is that when he gets it out of you, to do that piece of surgery, what they have to do is cut all the nerves. There's a bit like mining. The first thing they have to do to get to the prostate is go in just above your pelvic bone, and as they go in through there, they go through an area called the Cave of Retzius, and the Cave of Retzius is full of nerves. The first thing they have to do is cut all that out of the way to get to the prostate behind it. Those nerves are all the ones that are connected into your groin, so you're not going to have any feeling in your groin after that piece of surgery. Then they cut out the prostate, and because we're built this way, let's get straight to the point. The way you get an erection is that you have veins in your penis which have blood flowing through them all the time, and when your brain triggers an erection or whatever, it starts to close down the exit of those veins so that the pressure builds inside your cock and it grows. That requires nerves, and those nerves are unfortunately part of or attached to the outer shell of your prostate. They follow a line which comes in, I believe, behind your bladder, around your prostate, down your urethra and into your cock. So when they cut out your prostate, if they do a radical prostatectomy and just remove it all, with no, that term I reminded you of, nerve sparing. If there's no nerve sparing, it's because they've cut all those nerves, and you'll never ever have a natural erection again. I'm told there are injections and things like that that you can use to give yourself an erection, but I don't really know. I've not bothered investigating any further. It just seemed like at this point when I discovered this, it was like, okay, that's a big deal for someone who's 53. Plus the fact, when you talk to the surgeons about this procedure, they say, oh yeah. Incontinence. Just about everybody who has this surgery will be incontinent for a period after the surgery. Okay, you think so? Incontinent for a period. How long is it going to take before I stop wetting myself? And the answer is, for a third of all patients, within a month or so. For another third, within 6 months or so. And for the last third, maybe a year or maybe not at all. So, and let's just sort of do a worst case here. 1 in 3 patients who have this surgery are going to take at least a year before they stop wetting themselves after the surgery. And there's a whole load of stuff you can go and research about the way that you control how you pee, and why a radical prostatectomy affects that so dramatically. So in terms of recovering from this surgery, you have the surgery, you're going to be incontinent and impotent as well, and probably very, very uncomfortable and a lot of pain. Yeah, it's just not good. It's not good, but the result is you've got the cancer out. That's fine until they, in the interview with the surgeon, he also mentions that there'll be something called salvage radiotherapy. Okay, so let's put the surgery aside for a minute. Let's go and visit the radiotherapist. So, which is what I did. We go visit the radiotherapist. Radiotherapist is a really interesting man, knows his job. If you ever get the chance to meet Dr. Pod at Ipswich Hospital, he's a very knowledgeable man. I think he was deliberately doing worst case for me because he really, really, really wanted me to get the points. But let's just go through this. Radiotherapy is the radiation of your body with X-rays or some other type of radio frequency radiation, a bit like microwaving your insides. The idea is to basically toast it all. Salvage radiotherapy is because the surgeon, and it's going to sound disingenuous, and I'm sorry to the surgeons out there who might decide to watch this. The surgeons don't ever want to be accused of not doing their job properly when a patient 10 years on from the surgery dies of prostate cancer anyway. So what they do is they ask you, send you, tell you. They don't really offer it as a choice, it's just this is part of the treatment. They send you to go and have some salvage radiotherapy. Dr. Pod tells me that salvage radiotherapy is exactly the same as using radiotherapy as a primary treatment. They bombard your body with radiation, they toast your insides. Radiotherapy is used for lots of different sorts of cancer treatments, and for most of them it's not an issue. But for the prostate, it seems, it can be. And the reason it can be is because the prostate is buried so deep inside so many complex bits of tissue. And for the radiation to get to the area where the prostate once was and isn't anymore, they actually end up irradiating lots of other things like your bladder and your bowel. And the beams have to pass through a whole load of other complex and necessary structures like bones and things like that. And there's so much radiation that they need to give you for it to be worth doing that the things that they're kind of secondary to the primary treatment, the bowel and the bladder and the bones and things like that, 10 years on from the treatment are likely to be developing secondary tumours. That is to say, they are not prostate cancer, but they are another sort of cancer which has been started by the DNA radioactive damage to the other tissue and bones. What was made very clear to me by Dr. Pod was that the standard radiotherapy, which is can be offered as a primary treatment for prostate cancer, is an effective treatment if you're in the standard demographic for this type of this level of tumour. So if you're in your 70s and you have this type of tumour, this level of tumour, and they're probably not going to offer you surgery because you might not survive the surgery. It's quite a difficult bit of surgery. So they're going to offer you radiotherapy, and at that age they'll combine it with hormone therapy. The prostate cancer, the tumour grows in the prostate, which is saturated with testosterone, and only grows because it has testosterone. So the first thing they do is give you massive doses of hormone suppressants, the testosterone suppressants, and that actually stops the tumour from growing and can shrink it, and they'll tell you this makes the target smaller and makes it easier for the treatment for the radiotherapy to work. If you're 70 years old when you go for this, it's going to stop the prostate cancer from killing you. Your testosterone levels have probably already dropped significantly by that age anyway. For some people, they don't even notice that they've been put on a testosterone suppressant, and the risk of secondary tumours is going to be happening at a time when frankly you're going to be dying of old age anyway, so it's not considered an unsuitable treatment. To the extent that the clinical research data that they collect about patients they've treated doesn't bother going beyond 10 years because so many of the patients they're treating have died of old age by then anyway, and the sample's getting too small. How does that relate to me? At 53, if I have radiotherapy now, at 63 I'll be developing secondary tumours, and before I'm 70 I'll probably be dead. This is the point that Pod wanted to get across to me, was don't do radiotherapy for prostate cancer if you're 53. If you're considering it at the moment, please just go and ask some more questions before you do so. Um, what happens next? At this point, I'm thinking, okay, so I've got to go and have surgery, but this is, I'm struggling to find anything positive in all of this. I've got a disease, let's call it a disease, that's probably going to kill me if I do nothing. Well, in fact, actually, it's one of the questions I asked the surgeon. I said, what happens if I do nothing? He was uncomfortable about answering the question, but he did answer it eventually. Standard progression of this is that the tumour will continue to thrive on my testosterone-rich body. It will continue to grow. Ultimately, tumour cells which are already operating outside of the prostate are becoming less sensitive to testosterone and being able to survive in an environment which isn't saturated with testosterone. So they can then start jumping from the environment localized to the prostate into the bloodstream and the lymphatic system. They'll get distributed to other parts of my body where they might find themselves comfortably growing in my brain or my heart or my lungs or something like that, and then it's too late. Basically you're into chemotherapy and you've got maybe a 50-50 chance of living 2 years. I asked him how long it'll take to get from where I am to that point where, that tipping point where it jumps and we consider it no longer treatable. Interestingly, he said it would be probably a number of years, could be as many as 8 years before that happens. I'm not going to wait 8 years for treatment on the hope that it doesn't do that, but it perhaps tells you something about how slow this particular variety of prostate cancer does grow and where the risk really is. So at the moment I'm just living with some symptoms. I'm just living with a problem peeing. I'm also conscious of the fact that I'm fatigued. My body is fighting this. I find myself getting tired towards the end of the day and stuff like that. So it's got to be dealt with, and it looks very much like what I need is surgery, and what I don't need is radiotherapy. So we started talking to the surgeons again, saying, yeah, well, can we do this surgery? Can we do some nerve sparing? Can we do the surgery without the radiotherapy? None of the NHS surgeons were prepared to do that. So we widened our search, and I found a surgeon in the UK who does a thing called Retzius sparing. Retzius sparing robotic radical prostatectomy with frozen section biopsies. So this is actually what I'm going to do. Today is Monday. I'm going in for surgery on Wednesday this week. So wish me luck. Retzius sparing. I mentioned the Retzius earlier when I said how the surgery is usually done from the front and goes through the cave of Retzius. Well, Retzius sparing means that they come in from underneath rather than in front, and so they don't need to damage the cave of Retzius, which means they don't damage all those nerves. The radical prostatectomy is still a radical prostatectomy. They're still going to remove most of it, but I say most rather than all, because what they're going to do is they're going to open up the prostate, remove remove all the insides first of all, and then they're going to start working their way out, and they're going to use these frozen section biopsies, which is that they take small samples and they look for a safe margin. At the point, they'll continue to remove material until they can see that the entire surface of the material they've removed is free of tumour cells. That way they know they've removed everything they need to remove and they've left behind everything they possibly could. And hopefully what that will mean is they'll leave behind all the nerves. Now at the moment I can still get an erection, which tells me that the nerves aren't damaged, and if they can safely remove all of the tumour and all the affected tissue without damaging the nerves, then in theory I should still be able to get an erection after this. That also means that I'm very, very likely to be fully continent. That is, I'm not going to be wetting myself very, very soon after the surgery. We're talking a matter of days. So that's where I'm off to. I'm spending today and tomorrow just tidying up. I've got a list of things to do. I've got to go to the doctors and sort out the prescription for the medication I'm going to need when I come out of hospital. That's it. This is what we're doing. So this video has been about me, but it's also been about you. If you're male, you're anywhere from, I suppose, anything sexually mature into your 80s, then you could be, will be a victim of prostate cancer. If you're not aware of the basic symptoms to look for, then if you're having trouble peeing, it's a good place to start. If you want to know more, Prostate Cancer UK's website seems like a really good resource. It doesn't tell you everything. Nobody's going to tell you everything. You're going to have to ask questions. You're going to have to do a load of research. If you've got anything you think I can help you with, just leave a message at the bottom of this, and I'll respond. And I'll wish you luck, because if you can discover that you've got prostate cancer before it gets to the stage where that definition of your cancer, T3B in my case, if that was T3A, this would be a much simpler operation. And it might be that 6 months ago, if I'd discovered I had this, it would be a T3A, not a T3B. Get an early diagnosis. Go and find out as quickly as you can. It's probably, although it's scary to think what has to be done if you have got prostate cancer, personally I'd be more concerned about getting to the next stage without having done anything and knowing that I've probably only got 2 years to live if it gets into my bones. So that's it from me. I hope you've, at least, I'm not going to say I hope you've enjoyed this video, because it's fucking horrible. If I can do anything positive out of this, then the positive thing I'm going to do is someone out there is going to watch this video and they're going to get themselves diagnosed and treated, and they're not going to die unnecessarily of prostate cancer. Thanks, bye.